బాత్రూమ్ లైట్ బంద్ చేసి
All right, so a very good evening, everyone. So I welcome you all to this particular session on the connective tissue disorders rapid revision, right? So there is a small mistake in the thumbnail. It is actually written as neurology session, but it's a small correction from my side or from the team side. So it is not the neurology session today. So it is the connective tissue disorder rapid revision. Okay, right. So good evening, everyone. So I'll do a quick revision of all the connective tissue disorder topics within 1 or 1.5 hours. Okay, and once I finish this topic, I'll be sharing you this PDF. Okay, right, and you can join my Telegram channel. So my Telegram channel is Medicine Made Easy by Dr. Rajesh Gubba. So in this particular Telegram channel, I'll be sharing this immediately after the class. Okay, right. So let us start with the session. Just give me a minute. Okay, right. So before starting the session, right, so let me just tell you like what is going on an academy. So as a part of the Republic Day, right, so they have offered 20% discount on all the medical PG subscriptions. So you can just go through, and depending upon your need, you can just get subscribed to the Unacademy platform. And Unacademy is also providing the iconic subscription, where Unacademy, along with that, you get the prep ladder lectures as well. And we have the final booster batch which is coming up for NEET PG 2023, and that particular batch is starting from February 1st. So those students who are interested, so definitely you can subscribe to this particular batch course, which will be definitely useful for your upcoming NEET PG exam. And for the FMG students, that is for the FMG June batch, so Unacademy is starting up with Crack FMG 23 with FMG Mastery batch. So this, like, you have the 4 months batch course. So those students who are interested, you can just subscribe to this particular course, where definitely it will be useful for the upcoming FMG exam. Okay, right. So having said this, yes, Agastya, I will discuss the remaining part of the genetics. Once I finish the connective tissue disorders, I will discuss the remaining part of the genetics as well. Okay, right. Now let us start with the yes, Sahiti, glad to watch your videos for NEET PG, sir. Any rapid revision? Yeah, yes, Sahiti, I'll be doing the rapid revision sessions in the month of February for NEET PG as well. Okay, right. So having said this, let us start the discussion of this connective tissue disorders with the topic of the vasculitis. So now just go through the question and please answer this. Which of the following is not a large vessel vasculitis? Which of the following is not a large vessel vasculitis? So a very simple and straightforward question. Very good, Rudrakshi. So the answer is the idiopathic cutaneous vasculitis. Whereas, yes, I have expected that many of you might be going with Behçet syndrome, but let me tell you. So this large vessel, Takayasu and as well as giant cell, they are large vessel vasculitis. Whereas you take in case of Behçet's. In case of Behçet's, along with small vessel, there is also involvement of the large vessel. So it is both small and as well as the large vessel vasculitis. But whereas you take idiopathic cutaneous vasculitis, it is exclusively small vessel vasculitis. Now let me just quickly recap, right? Let me just quickly recap the the entire vasculitis. It just takes only 15 minutes for me to discuss all the types of vasculitis. So if you take the large vessel vasculitis, that includes giant cell arteritis and then the Takayasu arteritis. Okay, right. Whereas medium vessel vasculitis are the polyarteritis nodosa. Then we have Berger's disease, which is nothing but your thromboangiitis obliterans, then Kawasaki. So this will be medium vessel vasculitis. And what are the examples for small vessel vasculitis? The examples for small vessel vasculitis will be Henoch-Schonlein's purpura, Wegener's granulomatosis, Churg-Strauss syndrome, and microscopic polyangiitis. So these are all your small vessel vasculitis. Now, after having discussed about like what are all the various vasculitis, you need to know what is the most common cause of vasculitis in children. Most common cause of vasculitis in children, please remember, it is Henoch-Schonlein's purpura. It is not Kawasaki disease. So after Henoch-Schonlein's purpura, the next most common cause of vasculitis in children will be Kawasaki. But only point you have to remember is that Henoch-Schonlein's purpura, it is seen both in children and as well as adult. But if you take most common cause of vasculitis in children, that will be Henoch-Schonlein's purpura, right? And where is this reference from? This particular reference is from CMDT 2022. Right, so this is a standard line which is given from CMDT. Okay, now what is the most common cause of vasculitis in adults? Can anyone answer what is the most common cause of vasculitis in adults? So don't be under the impression it is giant cell arteritis. So it is idiopathic cutaneous vasculitis. Okay, idiopathic cutaneous vasculitis. Then followed by that giant cell arteritis. Then followed by the giant cell arteritis. So that will be the most common cause of vasculitis in adults, right? Now, after having said this, you should know the types of inflammation in case of vasculitis. You should know the types of inflammation within the vasculitis. Okay, so, right, I'm sorry. Right, if you take the granulomatous vasculitis, what are all the examples for granulomatous vasculitis? Your giant cell arteritis, Takayasu arteritis, then Churg-Strauss syndrome, and then Wegener's granulomatosis. All these conditions you will have granulomatous vasculitis. And what are the examples for non-granulomatous vasculitis? Non-granulomatous vasculitis are the remaining. Like what are those? Microscopic polyangiitis, then polyarteritis nodosa, Henoch-Schonlein's purpura, then Kawasaki disease. So these are all your non-granulomatous vasculitis, which is nothing but your necrotizing inflammation. Which is nothing but necrotizing inflammation. And what is very important in case of vasculitis is the antibodies. See, we have two important antibodies. One is the P ANCA and the other one is the C ANCA. And you should know what is the target. What are these? These are basically antibodies. Right? These are basically the antibodies. You take this P ANCA. What is the target antigen for the P ANCA? And what does this P stands for? Perinuclear region. And the target antigen for the P ANCA will be myeloperoxidase. And what is the target antigen for the C ANCA? The target antigen for C ANCA, that will be proteinase 3. Okay, the target antigen is proteinase 3. Now, what are the conditions where you have the P ANCA? The conditions where you will have P ANCA is microscopic polyangiitis, then Churg-Strauss syndrome. Then what are the conditions where you will have C ANCA? The C ANCA, you have that in patients with Wegener's granulomatosis. Okay, so these are the antibodies that you need to know within the vasculitis. Now let us discuss the individual vasculitis, right? So yes, so the target antigens are very, very important. For P ANCA, it is myeloperoxidase. For C ANCA, it is proteinase 3. Please remember this. Now you see this clinical question, that is a 24-year-old female presents with abdominal pain, right? Presents with abdominal pain, hematuria, and as well as arthralgia. On examination, there is palpable purpuric rash that is seen on the trunk, limbs, and as well as buttocks. The coagulation tests are normal. So what do you think is the most probable diagnosis in this patient? Very good. So it is a diagnosis suggestive of Henoch-Schonlein's purpura. Now let me discuss about the Henoch-Schonlein's purpura in crisp manner. So if you take this Henoch-Schonlein's purpura, you have a tetrad in case of Henoch-Schonlein's purpura. What is the tetrad in case of Henoch-Schonlein's purpura? The word H stands for hematuria. Okay, the word H stands for hematuria, and the word S stands for the skin purpura. Okay, that will be palpable purpura, and that particular palpable purpura is distributed over the trunks and as well as the lower extremities and even the buttocks. And P stands for pain, pain over the joints and as well as the abdomen. So this is a tetrad in patients with the Henoch-Schonlein's purpura. Now, what is the investigation of choice in these patients with the Henoch-Schonlein's purpura? That will be the skin biopsy. Right, skin biopsy, it is the investigation of choice, right? And what does that skin biopsy contain? Skin biopsy in these individuals contain leukocytoclastic vasculitis, right? It contains leukocytoclastic vasculitis, and in these vessels there will be accumulation of the immune complexes. There will be accumulation of immune complexes. And what does this immune complex contain? It contains IgA and as well as C3 component. This is what is the immune complex that will be deposited within the skin, and skin biopsy is considered as the investigation of choice. Then what is the drug of choice for the Henoch-Schonlein's purpura? Drug of choice for the Henoch-Schonlein's purpura will be the steroids. Okay, steroids are considered as the drug of choice. But again, and what is that steroid that we give is prednisolone. How much dose of prednisolone we give? 1 to 2 milligrams per kg per day orally has to be given. That is about the drug of choice in case of the Henoch-Schonlein's purpura. But in severe forms of the disease, in such case, if the patient does not respond to steroids, then the alternative drug will be rituximab. Right, the alternative drug will be rituximab. So rituximab treatment and as well as the plasma exchange have been successful for severe disease where the patient is not responding to the steroids. Okay, and in these individuals, this is what is your palpable purpura. Right, and where is this particular purpura being distributed? Mainly over the lower limbs, buttocks and as well as the trunk. So this completes the discussion of your Henoch-Schonlein's purpura. So let me quickly revise Henoch-Schonlein's purpura. It is characterized by a tetrad where there will be hematuria, there will be skin purpura, that is nothing but palpable purpura. The word P stands for pain within the joints and as well as pain within the abdomen. And pain within the abdomen will be the colicky type of pain. And you take pain within the joints, that will be polyarteritis, and that too there is involvement of the lower limb joints. And the investigation of choice will be the skin biopsy, which will contain leukocytoclastic vasculitis, and there will be also immune complexes where you have IgA and as well as C3. Drug of choice will be prednisolone. Dosage will be around 1 to 2 milligrams per kg per day orally. And in severe forms, we give rituximab and as well as the plasma exchange, right? And you have to remember that the platelets in these individuals will be absolutely normal. There will not be thrombocytopenia. In fact, there will be thrombocytosis. But why is that you will have this particular purpura? That is because of the cutaneous vasculitis. Because of cutaneous vasculitis, you have this particular purpura. So that is about your Henoch-Schonlein's purpura. Then after having discussed about the HSP, next you need to know the another important form of vasculitis, which is nothing but your Kawasaki disease. Now, can anyone tell me which of the following is considered as the drug of choice for Kawasaki disease? Cyclosporin, dapsone, intravenous immunoglobulin, methotrexate. So what do you think is the drug of choice? Very good. So it is your intravenous immunoglobulin which is considered as the drug of choice in patients with the Kawasaki disease. And Kawasaki is what? It is a medium vessel vasculitis, and it is very commonly seen in case of children. Right? And what are the characteristic features in patients with the Kawasaki disease? In patients with Kawasaki, there should definitely be presence of the fever, and this particular fever should be more than or equal to 5 days. And along with fever, there are certain manifestations that has to be present. Okay. Now, you remember this mnemonic, that is cream. So everyone is aware, like the small children, they are very much fond of the cream biscuits. Okay. So you just remember the word cream. And what does that cream stands for? Yeah. So C stands for conjunctivitis. But what is that you have to remember here very carefully is it is non-exudative conjunctivitis. Then R stands for rash. And it is polymorphous, right, non-vesicular rash. And E stands for edema, and this particular edema will be there within the hands and as well as feet. And adenopathy, this lymphadenopathy is very, very important. Where you will have this adenopathy, that is unilateral cervical lymphadenopathy, and that too which particular lymph nodes are involved? Posterior cervical lymphadenopathy will be there, and the size of the lymph nodes should be more than 1.5 centimeters. and M stands for mucosal involvement, where there is erythema or fissuring or crusting. So this is what is your cream. And out of these 5, how many manifestations should be there? If 4 are there, we can consider the diagnosis as the Kawasaki disease. So this image will give you complete picture of Kawasaki: fever more than 5 days, cervical lymphadenopathy, polymorphous non-vesicular rash, right? Then you have this conjunctivitis, non-exudative conjunctivitis, and in these individuals they will also have edema, and there will be also mucosal involvement, right? That is erythema or fissuring or crusting will be there. Okay, then what is the drug of choice in case of acute stage? In case of acute stage, yes, Mota, what was your question? Sir, do mixed bag PYQs rather than chapter wise at this point of time. Only 28 days left. We can't give 2 hours, just one topic, sir. Please do mixed bag previous year questions, PYQs. Yes, Mota Babi. Right. So Motababi, like we have one more month, that is February month. So in the February month, I will be discussing clinical based questions and as well as PYQs as well. Okay. Right. And those students who are like very much fond of the quick revisions, so these sessions will be very much useful. PYQs also I will do, but that will be done in the month of February. Okay. Right. Now you take acute stage. In acute stage, the drug of choice will be intravenous immunoglobulin and as well as the aspirin. Right, intravenous immunoglobulin and aspirin. Right, so this particular aspirin, yeah, so this particular aspirin, what is the adverse effect of the aspirin? There will be development of Ray's syndrome. Okay, and what is the problem in case of Ray's syndrome? There will be development of bronchial asthma. Right, that is what is your Ray's syndrome. Now in case of the convalescent stage, we just give only aspirin, and the dosage of aspirin will be around 3 to 5 milligrams per kg once daily, and you have to give it orally until 6 to 8 weeks illness onset. So that is what is your Kawasaki disease. Now tell me, in which condition you will have this particular tongue? Yes, in which condition you will have this particular tongue? Yes, any one of you? Medmix, I'll just take your point, Medmix, in the later part of the session because we are doing a quick revision of connective tissue disorders. Right, very good, Rachna. Yes, so you will not have this in case of the Kawasaki disease. In case of Kawasaki, what you will have is white strawberry tongue, and what is given here is a red strawberry tongue. So red strawberry tongue, that is seen in case of the scarlet fever. That is seen in case of scarlet fever. And what is the strawberry tongue that you will have in case of Kawasaki? Will be white strawberry tongue, right? And this particular scarlet fever is what? It is the one which is caused by your streptococcus, right? Streptococcus, right? Okay, right. Then now let us just revise all these particular strawberries, and this is one of the very famous question as well. So you take the strawberry nose. Strawberry nose, where do you get this? You get this in case of rhinosporidiasis. And where do you get this strawberry gingiva? You get this in patients with Wegener's granulomatosis. And where do you get this strawberry cervix? That is Trichomonas vaginalis. And where do you get this strawberry gallbladder? That you will get in case of cholesterosis. Okay, so this is about, right, so this is about your strawberry gallbladder. And apart from these strawberries, we have few more strawberries in medicine, right? What are those few more strawberries in medicine? Strawberry tongue, Kawasaki disease, and scarlet fever. Strawberry gingiva, Wegener's. But strawberry nasal mucosa, you will have that in case of sarcoidosis. Okay, and strawberry shaped skull, you will have that in case of Edwards syndrome. And strawberry nevus, you will have that in case of capillary hemangioma. And strawberry vagina, that is trichomoniasis. And strawberry lesion of rectosigmoid origin, and that is what is nothing but infection of Spirocheta winstii and Bacillus fusiformis. So these are all the strawberries. These are all the strawberries. Okay, right. So this finishes your Kawasaki disease. So let me quickly recap your Kawasaki disease. So Kawasaki is what? It's a medium vessel vasculitis. It is commonly seen in children, and the very important feature in Kawasaki should be fever more than 5 days, and along with fever there should be this cream. What is that cream? C stands for conjunctivitis, that is non-exudative conjunctivitis. R is polymorphous non-vesicular rash. E stands for edema. that is edema of hands or feet. A stands for adenopathy, that is cervical adenopathy or unilateral posterior cervical lymphadenopathy. M stands for mucosal involvement. Okay, and treatment in acute stage, you need to give intravenous immunoglobulin with aspirin, and in convalescent stage you need to give aspirin 3 to 5 milligrams per kg once daily. Orally you have to give, and you have to give that for nearly around 6 to 8 weeks. And all these are your strawberries. White strawberry tongue is what you will see in patients with the Kawasaki disease, right? Now, after having discussed about your Kawasaki, yes, a 20-year-old woman presents with bilateral conductive deafness, palpable purpura is seen on the legs and hemoptysis. Radiograph of the chest shows thin-walled cavity in the left lower zone. Right, thin-walled cavity in the left lower zone. Investigation revealed the leukocyte count of 12,000 per cubic millimeter. RBC is present within the urine, and serum creatinine levels are 3 milligrams per deciliter. What do you think is the most probable diagnosis in this patient? Yes, please answer this. Right, very good, Madhusri Datta. So the answer is the Wegener's granulomatosis. The answer is Wegener's granulomatosis. So Wegener's granulomatosis is what? Wegener's granulomatosis, it is a small vessel vasculitis. Okay, it's a small vessel vasculitis. Now, in case of Wegener's granulomatosis, you will have a triad of involvement. What is the triad of involvement? You have the upper respiratory tract involvement, right, where there can be involvement of your ear or the nasal manifestations. Lower respiratory tract involvement will be there. You can see the abnormality within the lung, and there will be also abnormality within the kidney. So this is a triad that you will have in patients with the Wegener's granulomatosis. Okay, right. Now, out of this particular triad, what is the most common manifestation? Okay, most common manifestation will be the upper respiratory tract involvement. And what will be the nasal abnormality in patients with the Wegener's granulomatosis? The nasal abnormality will be in the form of the saddle shaped nose. And why do you get this particular saddle shaped nose? That is because of septal perforation. And not only septal perforation, there will be also collapse of the nasal bridge, and thereby you get this particular saddle shaped nose. Okay, then followed by that, you need to know the lower respiratory tract involvement. Lower respiratory tract involvement, that will be in the form of cough, right? That will be in the form of cough. There can be also hemoptysis and as well as dyspnea. And whenever you take the chest X-ray in patients with the Wegener's granulomatosis, there will be multiple bilateral cavitatory nodular infiltrates. Okay, multiple bilateral cavitatory nodular infiltrates that will be there on the chest X-ray. And what will be the renal involvement? Renal involvement will be the third. That will be in the form of glomerulonephritis. And what type of glomerulonephritis is that? Crescentric glomerulonephritis will be there. Now, apart from these three, the other manifestations will be purpura. There will be palpable purpura, that is a skin manifestation. There can be also migratory arthritis. Ophthalmic involvement will be there, that is orbital pseudotumors can be there. And even peripheral nerve involvement will be there in the form of mononeuritis multiplex. Now, you take in case of Wegener's granulomatosis, right? And what is the investigation of choice will be C-ANCA, because C-ANCA is present only in case of Wegener's. That will be the investigation of choice. And what do you think is the drug of choice in patients with the Wegener's granulomatosis? It is not your steroids here, it is cyclophosphamide. Right, cyclophosphamide. Along with cyclophosphamide, we add the other drugs, right? What is that other drugs? That is steroids will be added. Okay, so the standard treatment for your Wegener's granulomatosis is mainly to induce the remission with immunosuppressants. And what is that immunosuppressants we give? Cyclophosphamide. You should give this cyclophosphamide along with high dose corticosteroids. And sometimes in very severe Wegener's granulomatosis, what we do is plasmapheresis. By doing plasmapheresis, we will take out that C-ANCA. Now, what do you understand by the word very severe Wegener's granulomatosis? Whenever there is diffuse alveolar hemorrhage, whenever there is rapidly progressive glomerulonephritis, that is the point when you need to do plasmapheresis. Okay, so that is about your Wegener's granulomatosis. Quick recap. So let me just quickly revise your Wegener's granulomatosis. It's a small vessel vasculitis. It's a granulomatous inflammation. You have a triad of involvement. The most common will be upper respiratory tract involvement. That is involvement of nose, ear and as well as throat. Nasal involvement will be in the form of saddle shaped nose due to septal perforation and collapse of the nasal bridge. Ear involvement will be in the form of conductive deafness. Throat involvement or mouth involvement will be in the form of strawberry gums. And lower respiratory tract involvement will be cough, hemoptysis, and dyspnea. Chest X-ray will show you multiple bilateral cavitatory nodular infiltrates. Kidney involvement will be in the form of crescentic glomerulonephritis, and skin involvement will be in the form of palpable purpura. Investigation of choice will be C-ANCA. Drug of choice will be cyclophosphamide. So this finishes. Right. So what do you mean by the word plasmapheresis? Okay, medmix. What is plasmapheresis is, we will do the filtration of the plasma, and in the plasma, this particular C-ANCA antibodies, whichever are there, they are being completely taken out by plasmapheresis. That is what is called plasmapheresis. Is that clear, medmix? Okay. Now, after having discussed about Wegener's, now we'll move on to the next one. That is, a young female presents with rhinitis. Not subsiding with antihistaminics, along with recurrent hemoptysis and the glomerulonephritis. Which of the following is not an important differential diagnosis to be considered in the given scenario? Wood-Passage syndrome, Wegener's granulomatosis, microscopic polyangiitis, polyarteritis, nodosa. Yes. Now, what is the answer? Any one of you? No, you cannot suspect Wood-Passage syndrome. Very good. Minu has answered it. Very good, Minu. That is polyarteritis nodosa. So what is one important point to tell it as polyarteritis nodosa is that in polyarteritis nodosa, there is no lung involvement. That's a very, very important point related to your polyarteritis nodosa. And if you take this polyarteritis nodosa, what is it? It is a medium vessel vasculitis. And in these individuals, you will have skin involvement. And the skin involvement in case of polyarteritis nodosa will be in the form of livedo reticularis. And that livedo reticularis is mainly seen in the lower limbs and as well as buttocks. And how will be the picture of livedo reticularis? So you will have this particular lacy skin pattern. That is what is called livedo reticularis, right? Then you also have the vasculitis of the peripheral nerves, and that will be in the form of mononeuritis multiplex. This mononeuritis multiplex is very common. So that is the vasculitis of the peripheral nerve. And there is also vasculitis of the gastrointestinal tract, where there is involvement of mesenteric vessels. And because of the involvement of mesenteric vessels, the patient will have the abdominal pain, right? And they will also have postprandial angina. Now, very important point is this polyarteritis nodosa is associated with hepatitis B. Hepatitis B is an established etiological agent, and it has a strong association with polyarteritis nodosa. And there is also vasculitis of the kidney, where there will be renal vasculitis. And because of that, there will be hypertension. What type of hypertension? Renovascular hypertension. And remember, there is no glomerulonephritis in patients with the polyarteritis nodosa. Joint involvement will be in the form of arthralgia. Cardiac involvement will be in the form of congestive cardiac failure. CNS involvement will be in the form of cerebrovascular accident. Then what does the biopsy show in patients with the polyarteritis nodosa? See, in patients with the polyarteritis nodosa, the biopsy will show you the presence of necrotizing inflammation. Biopsy will show you the presence of necrotizing inflammation. Then what is the drug of choice in patients with polyarteritis nodosa? It is the steroids that play an important role in the polyarteritis nodosa. Okay, so that finishes the topic of your PAN, right? A quick recap of PAN. So PAN is what? Medium vessel vasculitis. The necrotizing or non-granulomatous inflammation will be there. Skin involvement will be in the form of livedo reticularis. There can be also digital ischemia causing gangrene. Peripheral nerve involvement will be in the form of mononeuritis multiplex. GIT involvement will be in the form of mesenteric vasculitis causing abdominal pain and postprandial angina. Kidney involvement will be in the form of renovascular hypertension. Joint involvement will be in the form of arthralgia. Cardiac involvement in the form of congestive heart failure. CNS involvement in the form of cerebrovascular accident. Biopsy will show you non-granulomatous inflammation. Drug of choice will be steroids. Okay, so that finishes the topic of your PAN. Then another important small vessel vasculitis that we need to do a quick recap is the Churg-Strauss syndrome. So if you take Churg-Strauss syndrome, what is the type of inflammation that you will have in case of Churg-Strauss? That is the granulomatous inflammation. Then what about ANCA? So in these individuals, you have the P-ANCA, which is being positive. And what is the mean age of development of the Churg-Strauss syndrome is around the 48 years. The mean age is around 48 years. And if you take female to male ratio, so females, they are more affected than males for development of your Churg-Strauss syndrome. Now, what is the most common clinical feature that you come across in patients with Churg-Strauss syndrome? Most common symptom will be development of asthma. There can be severe asthmatic attacks and presence of pulmonary infiltrates. It dominates the clinical picture. It dominates the clinical picture. Then what is the second most clinical manifestation? That is in the form of mononeuritis multiplex. That will be the second most common manifestations. And the third manifestation will be in the form of allergic rhinitis. Right, the third manifestation will be in the form of allergic rhinitis. Okay, right. Then what are the skin manifestations in patients with the Churg-Strauss syndrome? On the skin, what is that you will observe is the presence of the purpura. Right, on the skin you will have the presence of the purpura, right, and there can be also skin nodules. And what will happen to the eosinophil levels? There will be significant eosinophilia in these patients. And how many eosinophils? That is more than 1000 cells per microliter will be there in these patients with the Churg-Strauss syndrome. Then what is the drug of choice? In these patients with Churg-Strauss syndrome, please remember the drug of choice will be steroids. And what is that particular steroid? That is, you need to give the prednisolone. And this particular steroid, you need to combine this with azathioprine. You need to combine this with azathioprine. Okay, right. And in those individuals who are not responding with your corticosteroids, in them we have the new drugs which have been approved by the FDA. And that is an interleukin 5 inhibitor. And what is that interleukin 5 inhibitor? That is mepolizumab. Mepolizumab is a new drug which is given for the treatment for Churg-Strauss syndrome. Okay, so that finishes about your Churg-Strauss. So let me quickly recap Churg-Strauss syndrome. Churg-Strauss syndrome is a small vessel vasculitis. The type of inflammation will be small vessel vasculitis. And what is the type of ANCA here? That will be positive P ANCA. The mean age is around 48 years. Females, they are more prone than compared to that of males. The most common clinical manifestation will be in the form of asthma. Second most common will be in the form of mononeuritis multiplex. And the third most common will be in the form of allergic rhinitis. And skin manifestations will be in the form of palpable purpura and as well as nodules, skin nodules. Eosinophil levels will be very much elevated, right? And drug of choice will be steroids that should be combined along with azathioprine. And the other alternative drug will be the mepolizumab, which is an interleukin 5 inhibitor. So that is about your Churg-Strauss syndrome, right? Then coming to the two important large vessel vasculitis, that is your Takayasu and as well as giant cell arteritis. So Takayasu is a large vessel vasculitis, and the most common vessel that is being affected is the left subclavian artery. So because of the involvement of the left subclavian artery, what will happen? The blood supply to your radial artery and ulnar artery will be reduced. So that is the reason why this Takayasu arteritis, it is also called as the pulseless disease. It is also called the pulseless disease. So the upper limb, the blood supply will be reduced. So that is the reason why these individuals, they will have reduced blood pressure and as well as decreased pulse in the hand which is being affected, and there will be unequal blood pressure between the right and as well as the left arm. And because of this, what will be the clinical manifestation? That will be in the form of arm claudication. Right, that will be in the form of arm claudication. So these individuals, on doing certain activities, there will be severe pain within the arm. So arm claudication, and not only that, there will be also development of Raynaud's phenomenon. So these are the vascular symptoms that you will come across in patients with the Takayasu arteritis. Now you should know, like, what is the most common variant of Takayasu in India? Type 1, type 2, type 3 and type 4. What is the most common variant of Takayasu in India? Yes. So the most common variant of the Takayasu in India, that will be type 3. Now, what is your type 3 Takayasu? Type 3 Takayasu is that where there is involvement of the arch of aorta and its branches. So basically your type 1 and type 2 together is nothing but type 3. Okay, combined features of both type 1 and type 2 is nothing but your type 3. So in case of type 3, there is involvement of arch of aorta and its branches, and there is also involvement of thoraco-abdominal aorta. Right, there is also involvement of thoraco-abdominal aorta. So this is what is your type 3 Takayasu, right, which is nothing but type 1 and type 2. Type 1 is what? Only there is involvement of arch of aorta and its branches. Type 2 is what? Thoraco-abdominal aorta and its branches are being affected. So in India, the most common will be type 3. Then what is the investigations? So in Takayasu arteritis, ESR will be elevated, and what will the aortography will show? The aortography will show you that there is presence of the ostial narrowing, right? Ostial narrowing, right? Yes, Asadullah, right? My great friend from Pakistan, right? So yes, because many of the students who are attending the session, they are from India. So type 3 is what is most common in India, right? Okay, then what is the investigation of choice? The investigation of choice in case of Takayasu will be MRI of the aorta. Then what is the drug of choice from Takayasu? Drug of choice for Takayasu. Drug of choice for Takayasu will be prednisolone. And what is the dosage of prednisolone? 1 milligram per kg for 1 month. Followed by that, you should taper over several months to 10 milligrams daily. That will be the mainstay of treatment. Now, in those individuals who are refractory to glucocorticoids, then what are the other alternative drugs? The other alternative drugs are the TNF alpha inhibitors, and that includes the infliximab, right? Or you have interleukin receptor antagonist, that is tocilizumab. Okay, so these are the drugs which we give in case of the refractory cases. So that completes the discussion of your Takayasu. So let me quickly recap Takayasu. Takayasu is a large vessel vasculitis where you will have granulomatous inflammation, and the most common vessel which is being affected is subclavian artery, and because of which there will be reduced blood supply to the upper limbs. So that is the reason why your Takayasu is considered as the pulseless disease, and these individuals, they'll have unequal blood pressures. And what will be the presenting symptom? That will be arm claudication, and there will be also Raynaud's phenomenon. And the most common form of Takayasu in India will be type 3, where there is involvement of arch of aorta and its branches, and thoracoabdominal aorta and as well as its branches. ESR will be elevated, iotography will show ostial narrowing, MRI of aorta is the investigation of choice. Drug of choice will be steroid, and in refractory cases we give infliximab or tocilizumab is being given. So that is about your Takayasu. Okay, then coming to the next, that is GCA, that is giant cell arteritis. So all of the following are true about the temporal arteritis. What is another name for your giant cell arteritis? The another name for your giant cell arteritis is nothing but temporal arteritis. So the question asks this, except which of the following will not be there, right? Very good. So they will not have low ESR. What they will have is increased ESR. Now let me just quickly recap about the giant cell arteritis. So what is the most common vessel that is being affected in case of giant cell arteritis is temporal arteritis, and the age group at which you see this temporal arteritis is more than 50 years. And what is the most common symptom in these patients with temporal arteritis will be headache, and that particular headache will be mainly unilateral headache, right? And if you palpate the temporal artery, it will be very tender to touch. Why? Because it's an inflamed temporal artery, and because of the inflammation of temporal artery, it is not only headache, the individual will also have jaw claudication. Now there will be also visual loss, and the visual loss, it is the most feared complication in case of your temporal arteritis, and that is due to involvement of posterior ciliary branch of, right, posterior ciliary branch of the ophthalmic artery. That is what is responsible for the development of visual loss. And what is the inflammatory marker that will decide the risk of blindness? That is the interleukin 6. And what are the other visual manifestation? That will be in the form of diplopia. That will be in the form of diplopia. Now apart from these symptoms due to vasculitis, you also have the symptoms of polymyalgia rheumatica. This polymyalgia rheumatica is present in almost 40% of patients, where there will be stiffness. Now where is this particular stiffness? You will observe the stiffness, you will have that in case of the shoulder girdle and as well as the hip girdle. Okay, in shoulder and as well as hip girdle, you will have this particular stiffness. Then what is the investigation of choice in patients with the Takayasu, giant cell arteritis? The investigation of choice will be biopsy. So when you do biopsy of the temporal artery, what is that you will observe is the presence of the granulomatous inflammation, and ESR will be definitely elevated. And how much will be that ESR? More than or equal to 50 mm per hour. That should be the ESR, right? Then what is the drug of choice in these individuals? That is definitely your prednisolone, that is steroids. Okay, so that completes the discussion of your giant cell arteritis. So let me quickly recap. The most common vessel affected is temporal artery, and the most common symptom will be unilateral headache. Because of the involvement of temporal artery, apart from headache, there can be also jaw claudication. Visual loss is mainly due to involvement of posterior ciliary branch of ophthalmic artery. And the inflammatory marker which is associated is interleukin 6 that will decide the risk of blindness. The other visual manifestations will be in the form of diplopia. Polymyalgia rheumatica is another important manifestation seen in 40% of patients, where there will be stiffness of shoulder girdle and as well as hip girdle, but it is more of shoulder than hip. Then ESR will be elevated more than 50 millimeters per hour, and the investigation of choice will be biopsy of the temporal artery, where there will be granulomatous inflammation, and drug of choice will be prednisolone. So this completes the discussion of your giant cell arteritis. Okay, right now, yes, the very important topic that we should not miss in the discussion of your giant cell arteritis is the SLE. Yes, please make an answer to this question. Right, so the question is, a 32-year-old man, long-standing diagnosis of SLE, is evaluated by her rheumatologist as routine follow-up. A new cardiac murmur is being heard and an echocardiogram is ordered. She is feeling well and no fever, weight loss or pre-existing cardiac disease. But the 2D echo is being done. Which of the following is the characteristic feature? That means which is a true point? Which of the following statements is true? Which of the following statements is true? Blood cultures are unlikely to be positive. Okay. Glucocorticoid therapy has been shown to lead to improvement in this condition. Pericarditis is frequently concomitant feature. The lesion has low risk of embolization. So, which is the true statement? Okay, so I did not get the correct answer from any one of you. I did not get the correct answer from any one of you. Blood cultures are unlikely to be positive, right? I'm sorry. One second. So I'm very sorry. One minute. So if you take the vegetations, so basically what is there in this picture? You are observing the vegetations, and what is this called as? This is called as Liebman-Sachs endocarditis. Now, how will be these vegetations? These vegetations, they are sterile vegetations. The vegetations are sterile vegetations. Okay. Where will you have non-sterile vegetations? You will have that in case of the infective endocarditis. Now you take cardiac manifestations in patients with the SLE. So pericarditis, that will be the most common manifestations in patients with SLE, but present concomitantly is a wrong statement. Pericarditis is the most common manifestation, but present concomitantly is a wrong statement. Next. Now, what is this patient having is Liebman-Sachs endocarditis. And in case of Liebman-Sachs endocarditis, the drug of choice is not steroids. Drug of choice is not steroids. So, what is that you have to do? You have to do valvuloplasty. That will be the treatment in patients with the systemic lupus erythematosus. Then lesions, they have low risk of embolization. See, these vegetations, like they are like friable vegetations. They have the risk of embolizations. It is not that they have low risk of embolization. Okay, and blood cultures are unlikely to be positive. That is the correct statement, because the vegetations what you will have in patients with SLE are the sterile vegetations. Non-sterile vegetations you will have in patients with the infective endocarditis. So the answer in this question is A, the true statement. Blood cultures are unlikely to be positive. That is a true statement, right? Now, in patients with SLE, Asadullah, the valve which has been shown here is the mitral valve. The vegetations are present over the mitral valve, right? And this is one of the famous mnemonic for your systemic lupus erythematosus. What is that? Soap brain MD. So you wash your brain with soap, then you get an MD seat. So that is what is your soap brain MD. So how many are there? There are totally 11 manifestations. Out of 11, 4 if they are positive, then it is very much suggestive of systemic lupus erythematosus. Now let me discuss all these manifestations. So what are these manifestations? First and foremost, you should know what is the most common presentation of SLE. Most common presentation of SLE will be fatigue. Then there can be fever. There can be arthralgia. there can be arthralgia. Okay, so that will be the most common manifestations, and followed by this fatigue, the next common manifestation will be hematological manifestation, and that hematological manifestation will be in the form of pancytopenia, and there will be also cutaneous manifestations, and cutaneous manifestations will be in the form of malar rash and as well as the discoid rash. And if the question is asked like what is the most common acute SLE rash, the most common acute SLE rash, that will be the malar rash. Okay, then what will be the description of this malar rash? It is fixed erythematous, it is flat or raised, they are present over the malar eminences, and these individuals, they will also have discoid rash, and these individuals, they are also at risk of the photosensitivity. Okay, and there will be also ulcers, right? That is the mucocutaneous ulcers will be there. So this will be the skin manifestations. And this regarding photosensitivity, one important point is there. Now, what is the antibody that is responsible for the development of this photosensitivity? That is the anti-Rho antibody, that is SSA antibody, right? And those individuals with anti-Rho antibody, they are at increased risk of photosensitivity. What is the treatment that you will give this for photosensitivity? Is hydroxychloroquine and as well as the sunscreen lotions, hydroxychloroquine and sunscreen lotions. And you take this joint involvement, that is arthritis. The type of arthritis that you will have in patients with SLE is non-erosive arthritis. This is very, very important point. So if you see this question here, in which of the following arthritis the erosions are not seen, that will be SLE. In SLE, what you get is non-erosive arthritis. Okay, right. Then followed by that, and the other manifestations can be in the form of synovitis. These are the musculoskeletal manifestations. Okay, right. Now let me discuss the all other multi-system involvement within the SLE. So if the question is asked like what is the most common lesion in the lupus nephritis, see the kidney involvement will be in the form of lupus nephritis. The most common lesion that you will get is the wire loop lesions. Okay, so this particular wire loop lesions, right, this particular wire loop lesions, they are mainly present in stage 4, right? So it is not stage 3, please remember it is in stage 4. Okay, right. Then what will be the cardiac involvement? The cardiac involvement will be in the form of pancarditis. But what will be the most common? The most common will be the pericarditis. And whenever there is pericarditis, the patient will have chest pain. That too, a pleuritic type of chest pain, and they will also have pericardial rub. And myocardial involvement will be there, that is in the form of congestive cardiac failure. Endocardial involvement will be there, that is in the form of Liebman-Sachs endocarditis. Now, what will be the lung involvement in patients with the SLE? So lung involvement, that can be in the form of the pleural effusion, and that too, that is exudative type of pleural effusion. And very rarely there can be development of shrinking lung syndrome. Now, why do you get this shrinking lung syndrome? That is due to diaphragmatic myopathy. So antibodies are formed against the diaphragmatic muscles where there will be paralysis of diaphragm, and due to which there will be elevated dome of diaphragm. That elevated dome of diaphragm will compress the lung parenchyma, resulting in the shrinking lung syndrome. And what will be the most common CNS manifestation? That will be in the form of cognitive impairment, and there will be also seizures. And most common psychiatric involvement, that will be in the form of psychosis. And what will be the hematological manifestation? That will be pancytopenia. And this particular pancytopenia, if you see, you will have hemolytic anemia. And what type of hemolytic anemia is? It's a Coombs positive hemolytic anemia. Why it is Coombs positive hemolytic anemia? Because it is antibody mediated hemolysis. Now, in almost 50% of patients with SLE, there will be development of Apla syndrome, which is nothing but hypercoagulable state, due to which there is recurrent abortion. Now, then followed by the drug-induced lupus. So, the most common drug causing drug-induced lupus will be procainamide. See, actually you have a big list of drugs. You have a big list of drugs, but the most common drug that will be causing drug-induced lupus will be the procainamide. So please remember this. Now, apart from procainamide, you have the other drugs as well. And in case of drug-induced lupus, like what is the marker? That is antihistone antibody. So let me just give you the list of drugs. We have antiarrhythmic drugs, the procainamide, disopyramide, and propafenone. And we have antihypertensives like hydralazine, ACE inhibitors, and beta blockers. We have anti-thyroid drugs, that is propylthiouracil, that can cause SLE. We have antipsychotics, that is chlorpromazine and as well as lithium. We have anticonvulsant, that is carbamazepine and phenytoin. We have antibiotics, that is isoniazid, minocycline and macrolidine. We have anti-rheumatic drugs, sulfasalazine, diuretics, hydrochlorothiazide, anti-hyperlipidemic agent, that is lovastatin and simvastatin. These are all the drugs that will cause SLE, but the most common will be the procainamide. Right now, what is very important in the discussion here is the antibodies. Right, very important is the antibodies. So what is the most sensitive marker for the SLE? The most sensitive marker for SLE will be the anti-nuclear, the antibody. And what is most specific? Most specific will be the anti-Smith. Right, most specific will be anti-Smith. And what is the antibody that tells you about the severity? The severity will be anti-DS DNA. Anti-DS DNA. And what is a marker for drug-induced lupus? Marker for drug-induced lupus will be the anti-histone antibody. And what is responsible for thrombus formation and recurrent abortion? That will be APLA, antiphospholipid antibody syndrome. Then what is the antibody causing psychosis in patients with SLE? Psychosis in patients will be anti-ribosomal P. Right, anti-ribosomal P. And what is the antibody that is responsible for photosensitivity? That is the anti-Rho. And what is the antibody that is responsible for CNS lupus? That will be anti-glutamate antibody. Right, anti-glutamate antibody, or it is also nothing but anti-neuronal antibody. Okay, so these are the antibodies that are responsible for the development of the various manifestations in patients with the SLE. Then how do you treat these patients with SLE is very important. What is the drug of choice in acute episodes? In case of acute episodes, it is prednisolone. That will be the drug of choice. And what about the other disorders? Whenever there is development of Libban-Sachs endocarditis, where there is involvement of endocardium, you need to do valvuloplasty. Right, you need to do valvuloplasty. You take APLA syndrome. If the patient with SLE, they develop APLA syndrome, you should give aspirin. Along with aspirin, you should give heparin or warfarin should be given. Okay. And whenever there is development of photosensitivity in patients with SLE, drug of choice will be hydroxychloroquine. And lupus nephritis patients with end-stage renal disease, they have to undergo renal transplantation. And what is the drug of choice for psychosis? For psychosis, it is haloperidol. Right, it is haloperidol. And what is the antibody that is responsible for psychosis? That is anti-ribosomal P antibody. And what is the drug of choice? Whenever there is severe lupus nephritis, whenever there is severe lupus nephritis, the drug that we give is the cyclophosphamide. And what is the drug of choice for SLE exacerbation in pregnancy? That is the hydroxychloroquine. And if required, we also need to add the steroids. And whenever there is severe lupus cerebritis, then the drug of choice will be dexamethasone. Okay, so this particular table is very important related to what is the treatment in patients with the SLE. So now let me just quickly recap SLE in 2 minutes. So what is the most common manifestation in patients with SLE? That will be in the form of the fatigue. There will be arthralgia, there will be fever, followed by that hematological and cutaneous manifestations will be there. And most common acute SLE rash will be malar rash, right? And which is nothing but your butterfly rash. And the other skin manifestations will be in the form of discoid rash and photosensitivity. And these patients with photosensitivity, hydroxychloroquine is a drug of choice. And mucocutaneous manifestations will be there in the form of oral ulcers, and joint involvement will be there in the form of non-erosive arthritis. And what will be the most common lesion in lupus nephritis? That is wire loop lesion, which is seen in patients with class 4 lupus nephritis. Cardiac involvement will be in the form of pancarditis. Lung involvement will be in the form of pleural effusion and shrinking lung syndrome. CNS manifestation will be in the form of cognitive defect. There will be also seizure. Psychiatric manifestation will be in the form of psychosis. Hematological manifestation will be pancytopenia, that is Coombs positive hemolytic anemia. APLA syndrome is seen in 50% of patients. Most common drug causing lupus will be procainamide. Okay, and you take the list of antibodies. Antibodies are very important in patients with the SLE. Now, what is the most most sensitive marker, that will be anti-nuclear antibody. Most specific, that is anti-Smith. Drug-induced lupus, anti-histone. Responsible for thrombus formation and recurrent abortion, APLA. Psychosis, anti-ribosomal P antibody. Photosensitivity, anti-Rho antibody. CNS lupus, anti-neuronal or anti-glutamate antibody. And drug of choice for acute episodes, that is methylprednisolone. Liebman-Sachs endocarditis, valvuloplasty. APLA syndrome, aspirin and anticoagulant should be given. Photosensitivity, hydroxychloroquine. Lupus nephritis with end-stage renal disease, renal transplantation. Drug of choice for severe lupus nephritis, cyclophosphamide. Psychosis, haloperidol should be given. Drug of choice for SLE exacerbation in pregnancy, you have to give the hydroxychloroquine and steroids if necessary. Severe lupus cerebritis, dexamethasone should be given. So this completes the discussion of your SLE. Now let me just quickly recap about this APLA syndrome. What is another name for APLA syndrome? Does anyone know what is another name for APLA syndrome? Right. So the another name for this APLA syndrome, this is also called as the Hughes syndrome. This is also called the Hughes syndrome. Okay. Right. So we have a terminology called as the catastrophic APLA syndrome. Catastrophic APLA syndrome is also called Asherman syndrome. Catastrophic APLA syndrome is also called Asherman syndrome. Basically, this APLA syndrome, it is a hypercoagulable state. It is a hypercoagulable state. And what is the name of the criteria for APLA syndrome? It is the Saparo criteria. Now, what will be there in case of your Saparo criteria? You have clinical criteria and you have lab criteria. Lab criteria, you have 3 antibodies. What are these 3 antibodies? Anti-cardiolipin antibody, that is IgG or IgM. Anti-beta-2 glycoprotein. Please remember, it is not anti-beta-2 microglobulin. It is anti-beta-2 glycoprotein. Then lupus anticoagulant. So these 3 will be the lab criteria. Right? These 3 will be the lab criteria. But which is the antibody which is at increased risk of the recurrent abortions? Right? Which is at increased risk of recurrent abortions? That will be the presence of lupus anticoagulant, that is at increased risk of recurrent abortions. Now, what will be the clinical criteria? The clinical criteria will be the vascular thrombosis and pregnancy morbidity will be there. That is mainly abortions. So you have to remember 2 things. More than 10 weeks, how many abortions? Less than 10 weeks, how many abortions? Less than 10 weeks, there should be more than or equal to 3 consecutive abortions. More than 10 weeks, death of the normal fetus, or premature birth at less than or equal to 34 weeks due to preeclampsia, placental insufficiency at less than 34 weeks. So this is what is your clinical criteria and laboratory criteria, which comes under your Saparo criteria. Then how do you treat these patients with APLA syndrome? So like the prophylaxis before conceiving, the patient should be taking aspirin. And once the patient has become pregnant, in this case, along with aspirin, you should give the anticoagulant. And what is that anticoagulant? We preferably give heparin. We don't give warfarin. Why? Because warfarin is associated with warfarin embryopathy. Right? So after this teratogenicity phase is over, that means after first trimester, you can give the warfarin. But preferable drug is the heparin. But the only problem with heparin is, like low molecular weight heparin is, it is very expensive. And it's an injectable agent. So that is the only disadvantage with your low molecular weight heparin. Otherwise, the LMWH will be more preferable rather than warfarin. So that is about your APLA syndrome. So let me quickly recap APLA syndrome. It is also called Hughes syndrome. We have a catastrophic APLA syndrome called Asherman syndrome. The name of the criteria will be Saparo criteria. You have a clinical and lab criteria. Lab criteria, 3 antibodies: anti-cardiolipin IgG or IgM antibody, anti-beta-2 glycoprotein 1, and lupus anticoagulant. These 3 antibodies should be there. And out of this, if the presence of lupus anticoagulant is there, the individual is at increased risk of abortions. The clinical criteria will be vascular thrombosis and pregnancy morbidity. So that is about your APLA syndrome. The prophylactic drug will be aspirin. And once the patient is conceived, then you should give aspirin along with that anticoagulant should be given. Right? So that finishes the topic of the APLA syndrome and as well as the SLE. Right. Then yes, we will discuss the 2 important topics, dermatomyositis and then the polymyositis. Dermatomyositis and polymyositis. as the name itself tells you, derma, that means skin involvement will be there. Myositis, that means muscle involvement will be there. Okay, so in these individuals, which particular muscles are affected? That is predominantly the proximal muscles which are being affected. And what will be the skin involvement? That will be in the form of rash. Now let me show you all these particular rashes and skin involvement. So this is the recent FMG question also, right? Coarctation of aorta, dark night. Okay, just give me some time. I'll come to that particular other topics because I'm in a flow of this discussion of connective tissue disorders. Okay, so the rash, what you get is the heliotrope rash. Okay, and where will be this particular rash? That is the periocular rash. There will be also the facial erythema, and this particular rash, it is pink or purple blue in color. Okay, purple blue discoloration, that is what is called heliotrope rash. And what are the other skin manifestations? The other skin manifestations will be in the form of the Gottron papules, right? We also call this as the Gottron sign. We also call this as Gottron sign. Where what is that you will have? You will have the presence of the violaceous papules which are present over the knuckles. And another important dermatological sign will be the V sign. Okay, that is erythematous rash over the body, that is mainly over the anterior part of the chest, that is V sign. And the differential diagnosis for your V sign, what is the differential diagnosis? You get even this necklace sign in case of the niacin deficiency, that is pellagra, and this particular necklace sign is nowhere related to your dermatomyositis. Okay, then the next important sign will be the shawl sign. So where you have erythematous rash over the body surfaces, including the upper trunk, neck, back, and even shoulders. That is what is called shawl sign. Then if you take the, yes, then if you observe the nails of these individuals, you will have dilated capillary loops, and these dilated capillary loops are present at the base of the fingernails, and that is what is called periungual telangiectasia. What is periungual telangiectasia? Dilated capillary loops at the base of the fingernails. And if you take the hands of these individuals, the description of these particular hands, we call it as the mechanic's hand, where you will have irregular, thickened, distorted skin will be there. The skin will be rough, the skin will be cracked, and that is what is called mechanic's hand, that you will have in patients with dermatomyositis. And followed by that, the calcinosis cutis, where there is development of or accumulation of the hard calcium deposits within the skin. So these are the cutaneous manifestations. Okay, right. So what are these cutaneous manifestations? Heliotrope rash, Gottron's papules, V sign, shawl sign, periungual telangiectasia, mechanic's hand, and as well as the calcinosis cutis, right? Now, after having discussed about this dermatological manifestations, which is there only in dermatomyositis, let me also discuss polymyositis now. So if you take this polymyositis, there is only involvement of muscle. In polymyositis, you don't have the skin involvement at all. And the other important difference is age. Polymyositis, it is seen around the age of 18 years, whereas the dermatomyositis, it is seen in the childhood and as well as the adulthood. Okay. Now, the other important point is that the malignancy. See, these dermatomyositis patients, 15% of patients, they are at increased risk of malignancy. Which particular malignancy is very common in dermatomyositis is there can be ovarian cancer, there can be bronchogenic carcinoma, there can be pancreatic cancer, there can be carcinoma stomach, there can be colorectal cancer, and there can be also development of non-Hodgkin's lymphoma. These malignancies are seen in dermatomyositis, but it is seen only in 15% of patients. Okay, and the other important difference is what polymyositis only muscle involvement, dermatomyositis along with muscle involvement, there will be skin involvement, and even there can be malignancy in 15% of patients. And muscle involvement may be mainly the proximal muscles which are being affected. Okay, so in upper limbs, if you see deltoid, biceps, and triceps, and in lower limbs, if you see it is quadriceps, hamstrings, and as well as the adductor group of muscles. So that will be the proximal muscles that are being affected in patients with the polymyositis or dermatomyositis. Then how do you investigate these patients? The investigation of these patients is mainly by your antibodies. You take this anti-Jovan antibodies. Anti-Jovan antibodies, they are present in patients with polymyositis, whereas anti-Mi2 antibodies, they are present in patients with dermatomyositis, whereas the anti-SRP, that is present in polymyositis or dermatomyositis. So because these are autoimmune disorders, so the antibodies are mainly present. So polymyositis, anti-Jovan; dermatomyositis, anti-Mi2; anti-SRP, it is present in both polymyositis or dermatomyositis. Then either you take in polymyositis or dermatomyositis, what do you think is the first line drug? The first line drug will be prednisolone. Right, the first line drug will be prednisolone. Okay, so daily you need to give 40 to 60 milligrams of the prednisolone. Okay, and what is the second line agent? Second line agent will be methotrexate. But when you give prednisolone for a longer duration of time, there will be development of Cushing syndrome. So in patients who are having like steroid resistant cases, in such case you need to give intravenous immunoglobulin. Intravenous immunoglobulin. So that finishes the topic of your polymyositis and as well as the dermatomyositis. Okay, so let me quickly recap this polymyositis and dermatomyositis. So dermatomyositis, skin and as well as proximal muscle involvement. Skin involvement will be in the form of heliotrope rash, Gottron's papule, V sign, Scholl sign, periungual telangiectasia, mechanic sign and calcinosis cutis. Then you take this polymyositis, only muscle involvement will be there, and that too proximal muscles. And the age group at which you see polymyositis is more than 18 years, and dermatomyositis adult and as well as the childhood. Okay, and malignancies. 15% of patients with dermatomyositis, they are at risk of malignancies. Which malignancy? Carcinoma ovary, lung carcinoma, pancreatic carcinoma, stomach carcinoma, colorectal cancer, non-Hodgkin's lymphoma. Right, and antibodies, if you see, anti-Jovan antibodies in polymyositis, anti-Mi2 antibodies in dermatomyositis, anti-SRP in polymyositis or dermatomyositis. Drug of choice will be corticosteroid, second line drug will be methotrexate, and steroid resistant cases you need to give intravenous immunoglobulins. Okay, so this is about your connective tissue disorder. This part of the connective tissue disorders I did not discuss on any other platform. Okay, so now let me discuss the other topics related to the connective tissue disorders, right? That is the ankylosing spondylitis. These topics, if you see, right, I have discussed even on the previous sessions also, right? So the first important, let me discuss this ankylosing spondylitis quickly. Yes, Mota Babi, what is the question, Mota Babi? Sir, in polymyositis, is it compulsory? What is it compulsory, Mota Babi? Okay, so yes, you just type your question. Meanwhile, let me just quickly recap this ankylosing spondylitis. So if you take this ankylosing spondylitis, what is the age of onset of this ankylosing spondylitis? That will be around 45 years. That will be around 45 years. What will be the important manifestations in these patients? That will be low back ache. Yeah, polymyositis, is it compulsory? Age less than 18 years. See, most commonly it is less than 18 years. Okay, polymyositis most commonly, more than 18 years. Most commonly it is more than 18 years. Which one? Polymyositis. It can occur even in children also, but most commonly more than 18 years. Okay, whenever we use the word most common, like we tell that, like depending upon the incidence. Depending upon the incidence. Okay, right. Now let me discuss about the ankylosing spondylitis. Ankylosing spondylitis, the age group at which you see this is mostly around 45 years. Low backache is seen, that will be there for more than 3 months. And why this low backache will be there? This particular low backache is mainly because of the sacroiliitis. So the important manifestations will be sacroiliitis should be there on imaging. Along with sacroiliitis, if more than one spondyloarthropathy feature is there, we call it as ankylosing spondylitis. Or the other criteria to call it as ankylosing spondylitis is the HLA-B27 should be positive. Along with that, more than 2 spondyloarthropathy features should be there. Right, more than 2 spondyloarthropathy features should be there. Then we use this word, the ankylosing spondylitis. And in patients with ankylosing spondylitis, you not only have articular manifestations, you will also have the extra articular manifestations. And the most common extra articular manifestation will be in the form of uveitis. That will be in the form of uveitis. Okay, and that too, it is anterior uveitis. And you take lung involvement. Lung involvement will be in the form of upper lobe fibrosis, right? And cardiac involvement will be in the form of aortic regurgitation, ischemic heart disease, and third degree AV block. And GAT manifestation will be in the form of the inflammatory bowel disease. Spine involvement will be in the form of cauda equina syndrome, and skin involvement will be in the form of psoriasis. Okay, so this will be the extra articular manifestations in patients with the ankylosing spondylitis. Now you should know about this very important sign in case of ankylosing spondylitis, that is Schober's sign. Schober's sign is used to evaluate the flexion of lumbar spine, chest expansion, pain with motion of the hip, the neck pain and stiffness. Yes, Schober's sign is used to evaluate. Very good, Chaudhary. So it is mainly used to evaluate the flexion of the lumbar spine. Now, why you have to assess this flexion of the lumbar spine? Because the vertebrae are fused. And if you take the X-ray of this particular vertebra, you get this characteristic bamboo spine because of the fusion of the vertebra. Right? So bamboo spine is a characteristic feature in patients with ankylosing spondylitis. And not only that, when you take the X-ray of the spine, you get this classical dagger sign. What is this particular dagger sign? Dagger sign is that where there is radiodense line, where there will be radiodense line which is related to ossification of supraspinous and interspinous ligaments. Right, which is related to ossification of supraspinous and interspinous ligaments, which is called as the dagger sign. Okay, and one more important X-ray finding is there will be destruction of the sacroiliac joint. Okay, sacroiliac joint is completely destroyed. Okay, that is what you can observe in the X-ray. Right, then what will be the first line treatment in patients with ankylosing spondylitis? That is NSAIDs. And which particular NSAID we give? That is indomethacin. So indomethacin is considered as the drug of choice. Okay, and in those individuals who are NSAID resistant, in them you need to give the TNF alpha inhibitors. Then we have new drugs which are given for the treatment of ankylosing spondylitis, that is interleukin 17A inhibitors. Right, so what are those interleukin 17A inhibitors? They include secukinumab, right, and the other drug is ixekizumab. Right, secukinumab and as well as the ixekizumab. So these are the interleukin 17A inhibitors. These are highly effective in the treatment of ankylosing spondylitis. So that finishes your ankylosing spondylitis. So let me quickly recap ankylosing spondylitis in a minute. Okay, so ankylosing spondylitis, please remember it is HLA-B27 which is being positive. And in these individuals, the classical features will be low back pain. And this low back pain should be there for more than 3 months. And the criteria is that there should be sacroiliitis on imaging. Along with that, there should be more than one spondyloarthropathy features, or the HLA-B27 should be positive plus more than 2 spondyloarthropathy features should be there. Most common extra articular involvement is the anterior uveitis. Lung involvement will be in the form of upper lobe fibrosis. Cardiac involvement will be in the form of aortic regurgitation, ischemic heart disease, and third degree AV block. And GAT involvement will be in the form of inflammatory bowel disease. Spine involvement will be in the form of cauda equina syndrome. Skin involvement will be in the form of psoriasis. Schober's sign is being done mainly to evaluate the flexion of the lumbar spine, right? And the X-ray of the spine, you get this characteristic bamboo spine, and you also get this dagger sign. And when you take the X-ray of sacroiliac joint, there is destruction of the sacroiliac joint. First line drug will be indomethacin, and those individuals who are resistant to this indomethacin, you need to give TNF alpha inhibitors. And the new drugs are interleukin 17A inhibitors, that is secukinumab and as well as ixekizumab. Okay, so that finishes the topic of ankylosing spondylitis, right? Then the next topic is the sarcoidosis. Next topic is sarcoidosis. So sarcoidosis is what? It is the one which is characterized by the non-caseating granuloma, right? Non-caseating granuloma. Right. See, Dr. Reformer, for ankylosing spondylitis, the investigations will be the HLA-B27. But this HLA-B27, that is not the investigation of choice, because HLA-B27 is positive in many other conditions. Then what is the investigation of choice is the imaging of the sacroiliac joint. right, imaging of sacroiliac joint, okay, and that too the MRI of the sacroiliac joint. That will be the investigation of choice. It is not HLA-B27 because it is positive in many other conditions. Okay, what are the other conditions where you have HLA-B27 being positive? Psoriatic arthritis, ankylosing spondylitis, inflammatory bowel disease, retest or reactive arthritis. These are all the other conditions where the HLA-B27 is being positive. Okay, right. Then I'm sorry. Right, then you should know that this sarcoidosis, it is a multi-system disorder, and what is the most common organ which is affected in sarcoidosis? That is lung involvement. And what will be the pulmonary manifestations in patients with the sarcoidosis? The most common pulmonary manifestation will be in the form of interstitial lung disease, right? And in 5% of patients, there will be development of pleural effusion, that is exudative type of pleural effusion. Followed by this pulmonary manifestation, the next most common will be lymph node lymphadenopathy. There will be bilateral lymphadenopathy seen in almost 75 to 90% of patients. Okay, and this bilateral hilar lymphadenopathy, that will be the hallmark. That will be the hallmark of the sarcoidosis. Then the skin involvement. The skin involvement will be in the form of the lupus pernio, where there will be purple blue shiny swollen lesion that is present over the nose, cheeks, lips, and as well as the ears. And the other important skin involvement will be in the form of the erythema nodosum. Okay, so these are like multi-system involvement, and even there can be involvement of eye in patients with sarcoidosis, where there will be in the form of uveitis. Kidney involvement will be there in the form of renal hypercalcemia, and nervous system involvement will be in the form of peripheral neuropathy. Skeletal muscle involvement will be there in the form of skeletal system involvement will be there in the form of arthritis. Then what is the investigation of choice? Investigation of choice will be biopsy. So when you do biopsy, you will have the presence of non-caseating granulomatous lesion. Then what will be the chest X-ray findings? One is your bilateral hilar lymphadenopathy. Apart from that, you have this Garland's triad, or which is also called 1, 2, 3 sign, and this is also called as pawnbroker sign. This is also called pawnbroker sign, where there will be right paratracheal lymph node enlargement, right hilar lymph node enlargement, and left hilar lymph node enlargement. This is what is called the Garland's triad, which is also known as 1, 2, 3 sign or pawnbroker sign. Okay, then followed by that, you need to know the gallium uptake studies. Followed by that, you need to know the gallium uptake studies. So in the gallium uptake studies, you get this panda sign and as well as lambda sign. See, what is this panda sign? Where there is gallium uptake within the lacrimal glands and as well as the parotid glands, whereas that is panda sign. Whereas lambda sign, if you take, that is due to increased gallium uptake in the paratracheal or pretracheal lymph nodes and as well as the hilar lymph nodes. Okay, then apart from this, you have a skin test, and this particular skin test is not being done in the present days. It is only of academic importance, and the name of the test is the Queen-Selzbach test. The name of the test will be Queen-Selzbach test, and in these individuals, the calcium levels will be elevated and angiotensin converting enzyme levels are also elevated. So presentation of the patient will be in the form of dry cough because interstitial lung disease will be there. Then what will be the drug of choice in patients with this sarcoidosis? Drug of choice will be the prednisolone, and this prednisolone you have to give at a dosage of 0.5 to 1 milligram per kg per day. And whenever you give prednisolone, what is the advantage of prednisolone? See, that will reduce the hypercalcemia, that will reduce the constitutional symptoms, that will reduce the iritis, that will reduce arthritis, that will also reduce the CNS involvement, that will also reduce granulomatous hepatitis. So all these manifestations will be reduced by giving this particular corticosteroids. But the only point is, if the individual is like corticosteroid refractory, corticosteroid refractory, in corticosteroid refractory cases, you should give the infliximab. Right, infliximab, or you can add methotrexate along with azathioprine. So these are the drugs that you need to give for the corticosteroid refractory cases. So this is about your sarcoidosis. So sarcoidosis, let me quickly recap quickly, sarcoidosis is a form of non-caseating granuloma, and the most common organ which is affected is lung involvement, that is in the form of interstitial lung disease, and only in 5% of patients you will have the pleural effusion, that too exudative type of pleural effusion. Lymph node involvement will be there, that is in the form of bilateral hilar lymphadenopathy. Skin involvement will be there in the form of lupus pernio and erythema nodosum, and the others, eye involvement will be in the form of uveitis, kidney involvement will be in the form of renal hypercalcemia, skeletal involvement will be in the form of arthritis, nervous system involvement will be in the form of peripheral neuropathy. Investigation of choice will be biopsy showing non-caseating granuloma. The chest X-ray will show you bilateral hilar lymphadenopathy or Garland striate, which is also called 1-2-3 sign or pawnbroker sign. And gallium uptake studies will show you lambda sign and panda sign. Skin test will be Queen-Silsback test. Drug of choice will be prednisolone, and in corticosteroid refractory cases, you need to give infliximab or methotrexate along with azathioprine should be given. So this is about your sarcoidosis. Okay, next. Then the another important disorder that we need to discuss in the that will be the Sjogren syndrome, okay, where the patient will have dry eyes and as well as dry mouth. So that is another very important area where we should not miss the discussion. Just give me a minute, I am just opening that. Yeah, answer this. Yes. Yeah, Sika syndrome is associated with all except Sika syndrome is associated with all except midline granuloma, chronic active hepatitis, rheumatoid arthritis, scleroderma. Yes, any one of you please. Chronic active hepatitis can be seen in patients with Sika syndrome. Sika syndrome can also have rheumatoid arthritis. Sika syndrome can also have the scleroderma. What is that you don't have in Sika syndrome is midline granuloma. Okay, I will discuss this. Don't worry at all. Okay, so the answer is A. Now, you take this Sjogren syndrome. So in Sjogren syndrome, what is very, very important is the glandular involvement. What is that glandular involvement? That is the involvement of lacrimal gland, right, and involvement of salivary gland. So basically, it's an autoimmune disorder. Basically, it is an autoimmune disorder where the antibodies, they infiltrate. Which particular antibodies? CD4 plus T lymphocytes. These lymphocytes, they infiltrate into the gland, they produce the antibody. And what are these antibodies? The anti-Rho and as well as the anti-La. That is nothing but your SSA and SSB antibodies. And they destroy the lacrimal gland and salivary gland. Thereby the individual will have dry eyes and as well as dry mouth. Dry eyes is nothing but your keratoconjunctivitis sicca. Dry mouth is nothing but your xerostomia. But in females particularly, if you see, along with dry eyes and dry mouth, there will be also dry vagina. Why is this particular dry vagina? That is due to involvement of Bartholin's gland. That is due to destruction of the Bartholin's gland. And because of the dry vagina, the female will have a painful intercourse during the intercourse. And the terminology that we give is dyspareunia. Okay, so these are the glandular manifestations. Now, what is the viral infection that is associated with the development of your Sjogren syndrome is the hepatitis C. Then, what is the most common extraglandular manifestations? See, there are many extraglandular manifestations. Most common will be the arthritis. What are the other extraglandular manifestations? There can be arthritis, Raynaud's phenomenon, renal tubular acidosis, vasculitis, lymphoma. These are all the extraglandular manifestations. Okay, right. Now, you need to know primary Sjogren's and secondary Sjogren's. What do you mean by the word primary Sjogren's? The word primary Sjogren's means it is an isolated disorder. That means there will be only Sjogren syndrome. Right, there will be only Sjogren syndrome. Now, what do you mean by the word secondary Sjogren's? Secondary Sjogren's means along with Sjogren syndrome, there will be other associated connective tissue disorders. There will be other associated connective tissue disorders. What are those other associated connective tissue disorders? There can be rheumatoid arthritis, which is being associated. There can be systemic lupus erythematosus, which is being associated. Scleroderma, mixed connective tissue disorder, primary biliary cirrhosis, vasculitis, chronic active hepatitis. Okay, so these all, they come under this secondary Sjogren's. That means Sjogren's associated with other connective tissue disorders. That is what is called secondary Sjogren's. Whereas, what do you mean by the word primary Sjogren's? In primary Sjogren's, you have only Sjogren's syndrome. Okay, right. Then, what is the very, very important differential diagnosis for Sjogren's syndrome? The very important differential diagnosis for Sjogren's syndrome is uveitis. Where do you get this uveitis? That is in case of sarcoidosis. And in case of sarcoidosis also, there will be infiltration of the lacrimal glands and salivary glands by non-caseating granuloma. So this non-caseating granuloma will also infiltrate the salivary glands and lacrimal glands, and they will destroy the glands, and thereby the individual will have dry eyes and dry mouth. But the difference between your uveitis or Hereford syndrome and as well as Sjogren's syndrome is pathology or pathogenesis. In case of Sjogren's syndrome, it is the infiltration of CD4 plus T lymphocytes. Whereas in case of Hereford syndrome or uveitis, it is the infiltration of non-caseating granuloma. That is the important difference. Okay. Now, what is the antibody in Sjogren's we have discussed? That is anti-Rho and as well as the anti-La. But what is the investigation of choice in patients with Sjogren's? It is not the antibodies. It is the biopsy. And whenever you do biopsy, what is that you will observe in case of Sjogren's syndrome? You will observe the presence of CD4 plus T lymphocytes. Okay, you will observe the presence of activated CD4 plus T helper cells. That is what you will see in the biopsy in patients with the Sjogren's syndrome. Okay, then what happens about the salivary secretion in these patients with the Sjogren's syndrome? The salivary secretion will be reduced. How much is the normal salivary secretion? Normal salivary secretion will be around 1 to 2 ml per minute. 1 to 2 ml per minute. That will be the normal salivary secretion. But here in patients with the Sjogren's syndrome, the salivary secretion will be reduced to less than 1.5 ml in 15 minutes. Less than 1.5 ml in 15 minutes. That will be the salivary secretion in patients with the Sjogren's syndrome. Then what will happen to the tear secretion? Even the tear secretion also will be reduced. And what is the test we do here? The test what we do here is called as the Schimmer's test. The test what we do is called the Schimmer's test. So if you take the Schimmer's test, this litmus paper or the test strip, you need to hang over the lower lid. When will you call normal tear production? Then whenever almost up to 15 to 20 centimeters of this particular strip, if it is blotted by the tear, that is normal tear secretion. But if the tear secretion, if the blotting is less than 10 centimeter, we call it as the insufficient tear secretion. Okay, so that is what is your Schimmer's test. That is what is your Schimmer's test. Then how do you treat these patients with the Sjogren's syndrome? See, first important is the eye care. The eye care. So for the eye care, you need to give artificial tears. Right? You need to give artificial tears. Otherwise, there is like dryness of the eye. So moisture replacement therapies are very, very important. Then the other drug is cyclosporin. What is the cyclosporin? Cyclosporin is available by prescription only. That will suppress the inflammation. That will suppress the inflammation of the lacrimal and salivary glands. Then coming to the vaginal dryness. These patients, because of the involvement of the Bartholin's gland, there is vaginal dryness. And because of vaginal dryness, the individual is having dyspareunia, for which the individual has to use personal lubricants. Then musculoskeletal manifestations. What did I tell you? Most common extraglandular manifestation will be in the form of arthritis. And for arthritis, what we give is the NSAIDs. Right? And what are the other immunosuppressive drugs we give apart from cyclosporin? Whenever there is severe complications, right? Whenever there is severe complications, the other drugs that can be given is the intravenous immunoglobulins. Intravenous immunoglobulins. And whenever there is systemic involvement in patients with the Sjogren's syndrome, that is the point when we give even rituximab. Okay, so that is about your Sjogren's syndrome. Quick recap. So Sjogren syndrome, if you see, Sjogren syndrome, it is the one where the individual will have glandular manifestations. That will be in the form of the dry eyes and as well as dry mouth. That is due to destruction of lacrimal gland and salivary glands. And there is infiltration of CD4 plus T lymphocytes. The antibodies are anti-Rho and anti-La. The viral infection which is associated is hepatitis C infection. Most common extraglandular manifestation will be arthritis. Primary Sjogren's means you will have only Sjogren's, no other associated connective tissue disorders. Secondary Sjogren's means you have associated connective tissue disorders in the form of rheumatoid arthritis, mixed connective tissue disorders, systemic lupus erythematosus, chronic active hepatitis, vasculitis, all others. Differential diagnosis for Sjogren's will be sarcoidosis, where there is infiltration of non-caseating granuloma in the lacrimal and salivary gland, where the patient will have dry eyes and dry mouth. And antibodies in Sjogren's will be anti-Rho and anti-La, which is nothing but SSA and SSB. And investigation of choice will be biopsy. And if you take the salivary secretion, that will be reduced. And in Sjogren's, it will be less than 1.5 ml in 15 minutes. The Schimmer's test will show you that there is decreased tear secretion. And for the eye care, you need to give artificial tears. Cyclosporin will suppress the inflammation. For arthritis, you need to give NSAIDs. For severe complications, you need to give intravenous immunoglobulin. And whenever there is systemic involvement, you need to give rituximab. Okay, so that is about your biopsy of the lip. Yes, Varun, you are correct. So this is about your Sjogren syndrome, right? So with this, I'm done with the important topics. And rheumatoid arthritis is another important topic. And I don't want to discuss that because that's a very common topic which you might have read many times. Okay, so these are some of the important topics in the connective tissue disorders, right? So now I will just send this particular PDF to my Telegram channel, that is Medicine Made Easy. So you can just download this PPT from my Telegram channel, right? And on my Telegram channel, you can text me what are the topics that you want for short discussion. Okay, some of you were asking me about coarctation of aorta. Yes, dark night. This coarctation of aorta, I will make a short video clip and then I will post it in the Medicine Made Easy. I'll post it in Medicine Made Easy Telegram channel. Okay, so I'll do that. Definitely I'll do that. Don't worry about it. Right. So with this, I'm done with this particular session. So tomorrow, let us do the neurology revision. Basically, in this neurology, I'll try to concentrate mainly on the clinical based discussion. Mainly I'll concentrate on the clinical based questions on the neurology, because the neurology revision, right, I have done previously also. The 2-hour revision sessions are there on the YouTube itself. So that is mine only. And I don't want to do the same again. So I will do the clinical based questions on the neurology tomorrow, right? So the timing will be the same, that is 9 p.m. Okay. And yeah, Varun, I think you are the one who have asked about the hematology. Yes, but this particular hematology, I will definitely do the short revision. That is 2 hours revision I will do for the hematology, because I did not do hematology anywhere. So definitely I will do this particular hematology revision. But tomorrow it will be the neurology, right? Okay. Right. One last question we will take about Rachna and then we will wind up this session. Okay. Rachna is asking about upper motor neuron and as well as lower motor neuron lesion. Pandey, I have already discussed about ABG. You just join my Telegram channel, Pandey. I will send you the link of ABG. Recently, I have done the session on ABG, arterial blood gas analysis. So you just join my Telegram channel, Medicine Made Easy, and you text me. I will send you the link of the ABG. Okay. Yes, life in great moment. You can send me whatever your doubts are there. Either directly you can send me or you can text me on my WhatsApp also, right? Previously also I have given my WhatsApp number, that is 9686 241 211. This is my WhatsApp number. So you can directly text me on my WhatsApp itself. Okay, right. Now Rachna, upper motor neuron and lower motor neuron. See, in upper motor neuron lesions, what you will have is the tone will be increased. And that we call it as the spasticity. Whereas in lower motor neuron lesion, the tone will be reduced, and that we call it as the flaccidity. Okay. And what are your upper motor neurons? Either your corticospinal tract or corticobulbar tract. Corticospinal tract will be at the level of spinal cord. Corticobulbar tract will be at the level of your brainstem. Lower motor neuron, if you see, the lower motor neuron will be the anterior horn cell at the level of spinal cord, and beyond the spinal cord, it is the peripheral nerve or even the cranial nerve is also the lower motor neuron. Then what will happen to deep tendon reflexes? In upper motor neuron lesion, the deep tendon reflexes will be exaggerated. Then in lower motor neuron lesion, the deep tendon reflexes will be absent. Okay, and the next important is the plantar reflex. So the plantar reflex, if you see, there will be upgoing plantars in upper motor neuron lesion, whereas in lower motor neuron lesion there will be plantar flexion. The plantar flexion, and this upgoing plantars we call it as the Babinski sign positive. The Babinski sign positive. That is what you will see in case of the upper motor neuron lesion. Okay. Then the muscles which are being affected is in upper motor neuron lesion, it is the group of muscles which are being affected. Whereas in lower motor neuron lesion, it is the single group of muscles, or it is a single muscle which is being affected in lower motor neuron lesion. Then involuntary movements. There is no involuntary movements in upper motor neuron lesion, whereas in lower motor neuron lesion you will have the presence of the fasciculations. Okay, so these are the differences between upper motor neuron and as well as the lower motor neuron lesion. Yes, Rachna, is this clear, Rachna? Is this what you are asking me? Right, Sharmila, that is what I was telling you, Sharmila. The acid-base disorders I have already discussed recently on the YouTube itself. So you just please join my Telegram channel, Medicine Made Easy. I will send you the link of the acid-base disorders. My Telegram channel is Medicine Made Easy by Dr. Rajesh Gubba. So you just join there. I will just send you the link of acid-base disorders, which I have done recently on the YouTube. Okay. Right. So thank you very much. See you tomorrow.